Welcome to our third and final panel of the International Institute Conference on Gender and Health. I'm pleased to introduce our moderator for this panel discussion, Cynthia Gabriel. Cynthia Gabriel is a medical anthropologist specializing in reproductive health. She's a doula who actively attends births to stay current with their understanding of birth practices. She has conducted research on vaginal and cesarean birth in Russia, Canada, the United States, and Brazil. In Southeast Michigan, she is focused on understanding Black women's choices and the constraints of these choices during pregnancy and childbirth. Her most current research project investigates the experiences of Muslim patients and refugees in the US healthcare system. In addition, she has a special interest in LGBTQ reproduction issues. So without further ado, I hand this over to Cynthia. Thank you so much.
I'm happy to be here to welcome you to our panel on collective and gendered bodies, visualizing health. This will go roughly until 5 o'clock. And we have 4 great speakers lined up for you today. We have Tuğçe Kayaal, an assistant professor of history at Furman University. Yiming Wang, a master's student in international regional studies, specializing in Chinese studies at the University of Michigan. We have Stephanie Koning, who is at the National Institutes of Health as a postdoc fellow, which is at Northwestern University. And Kasia Klasa, who's a PhD candidate in our School of Public Health here at University of Michigan in Health Services Organization and Policy. And if you have read the abstracts, you know that we have some great papers ahead of us. So let me introduce our first speaker. We'll be hosting a Q&A session after all the panelists have given their talks. You can submit your questions using the Q&A function anytime during the panel. So if you have a question during the talk, go ahead and write it in there during that talk. Our first speaker will be Tuğçe Kayaal. Tuğçe Kayaal is an assistant professor of the Modern Middle East and Islamic World at Furman University in the History Department. She received her PhD in Near Eastern Studies from University of Michigan here in Ann Arbor, and she completed the Women's Studies Certificate program in my department. Her research and teaching interests incorporate sociocultural history of the late Ottoman Empire in the early Republic of Turkey, history of childhood and youth sexuality, history of bodies and sexualities in the Middle East, love, intimacy, and sexual desire in the late Ottoman and early Republic of Turkey, queer youth cultures in the Middle East. I really want to read about that. Discourses of sexual deviancy in the Ottoman Empire. Kayaal's dissertation, Wartime Bodies, Politics of Sexuality and War Orphans in the Late Ottoman Empire, 1913 to 1923, explores the efforts of the Ottoman Empire that they took to regulate sexual behaviors of war orphans during the Balkan Wars and World War I. Her research investigates how age, sex, ethnicity, and religion-based categories intertwine with and mutually inform each other in cultivating colonial subjects. So we welcome you to give this talk.
Thank you so much, Cynthia, for this kind and generous introduction. So can I share my screen, Gabriel, or? So do you see my PowerPoint presentation or?
Yes, we do.
Okay, perfect. So thank you so much for having me here. As I said, and I would like to especially thank the International Institute and Armenian Studies. It's nice to be back home, even virtually. So today I will talk about the cultivation of heteromasculine subjectivities among the Ottoman youth by focusing on the Turkish and Armenian Boy Scout organizations of the early 20th century. By expanding military training outside the barracks, Boy Scout organizations define the notion of patriotism and nationalist devotion through a militarized youth culture. In this paper, I will analyze these paramilitary organizations through an intersectional lens by underlining their role in shaping Ottoman male youth's heteromasculine subjectivity, bodily and social ideals, and national belonging by making 2 main arguments. First, I argue that these institutions thrust upon a particular notion of healthy male anatomy by employing a strict admission guidelines and training curricula. Second, the form of homosocial bound Boy Scout organizations rely on was also instrumental in forming the ideal healthy masculinity and male anatomy by emphasizing proper sexual conduct and socialization. Especially during World War I, the healthy masculine body and subjectivity, informed through nationalist and positivist perspectives, strictly shaped the Ottoman nation and citizen-making practices that particularly targeted children and youth. The ideological and socio-political setting of the early 20th century Ottoman Empire informed the state's ambition of cultivating the ideal Ottoman citizen. The 1908 Young Turk Revolution, led by the Committee of Union and Progress, promoted the definition of a new vision of Ottoman nation and citizenship. The initial message of freedom and equality for everyone, preached by the revolutionaries, changed significantly as the CUP embraced an ideology of Turkish nationalism that defined the ideal Ottoman citizen as a Turkish, Muslim, and heterosexual man, during and after the Balkan Wars in particular. The CUP government and Turkish nationalist elites carried over this notion of ideal Ottoman citizen to World War I. The large-scale mobilization of the Ottoman state's material and human resources for war purposes had both destructive and transformative impacts on the imperial infrastructure. In addition to large number of casualties on the battlefront, millions of people died from violence, famine, and diseases on the home front. Especially pandemics and sexually transmitted diseases killed many Ottomans during World War I due to the lack of effective treatment at the provincial and imperial level. Amidst all the destruction, chaos, and the immense need for human resources, children and youth became the main targets of the Ottoman wartime mobilization policies. In No Future, Queer Theory and Death Drive, Lee Edelman introduces the concept of figural child and his ideological function as a political tool deployed by nation states in cultivating a quote-unquote collective future. Especially in moments of collective trauma and crisis, the figural child stands as a futuristic figure holding a key to, quote, a brave new world of revolutionary possibility, end quote. The figural child, as Edelman argues, represents the ideal the citizen as an ideal and is entitled to claim full right to its future share in the nation's good. In the wartime Ottoman context, this figural child was the able-bodied, Turkish, Muslim, and heterosexual boy. In other words, the Ottoman construction of figural child reduced masculinity and manhood to norms of heterosexual sex with presumed healthy physical features and military heroism in late Ottoman society. Wartime childhood and youth literature, which was largely consumed by the male high school students, propagated this masculine ideal to recruit boys for the state's war effort by promoting the figural child as a national ideal. As a popular fictional character widely used in such texts, Little Mehmet or Küçük Mehmet or Mehmetçik in Turkish embodied the heteromasculine attributes that the Ottoman state desired to inculcate in its male youth. As historian Yiğit Akın shows in his book on the Ottoman home front, Little Mehmet, a young able-bodied Turkish Muslim soldier, was portrayed in the official propaganda as a pious and patriotic man who put the state, nation, and religion above his own life and interests. His strong commitment to his national and religious obligations meant that Little Mehmet left his family behind without hesitation to rush to the battlefront. Much like an Ottoman version of the British Tommy Atkins, the Unionist CUP government deployed Little Mehmet as an ideological tool to mobilize youth. Ottoman Boy Scout organizations functioned as militarized spaces where male youth and children who were too young for military service received military training and prepared for their future responsibilities as citizen soldiers. Such institutions aimed at cultivating figural Ottoman child or ideal masculine subjects, heteromasculine subjects, who were physically strong, healthy, and had proper quote-unquote moral integrity. According to the state and its institutional allies, feminization, in Turkish kadınlaşma, of Ottoman boys and men had caused the Ottoman army's defeat in the Balkan Wars. To avoid the same day's destiny in World War I and prevent the emasculation of Ottoman youth, the state promoted Boy Scout organizations, especially in the provinces where young boys lacked access to public schools. In the early 20th century, the CUP government cooperated with Boy Scout organizations to incorporate scouting activities into middle and high school curricula as well. In 1914, Istanbul, Bursa, and Edirne were three main urban areas where Boy Scout organizations were highly active and influential in training young boys. The same year, Ottoman Boy Scouts published a charter describing the institution's main principles. This 20-page booklet titled İzci Hoca'nın İç Nizamnamesi, Charter of Scout Troop, manifests the Ottoman state's desire to export a military-like social hierarchy from the army and military barracks to the daily lives of its youth. The training that scouts received was designed to cultivate citizen soldiers with overtly masculine characteristics starting in childhood. The articles in the charter, especially the section on the regulation of the organization's ranks and on receiving titles, project the essence of the ideal citizen soldier that the wartime state sought to cultivate and how it was interwoven with the state's perception of manhood and ideal masculinity. Sami Kayaal, a prominent Turkish nationalist educator and later journalist who published various studies on sports and physical health, defined the mission of the Boy Scout organization in his 1915 book titled İzci Rehberi, Boy Scouts Guide, as, quote, "Scouting is never only about climbing the mountains, hiking for kilometers. It is not his clothes that distinguishes a Boy Scout from the others. It is his personality. A proper Scout is the one who is known for good health and moral decency," end quote. From the perspective of nationalist ideologues like Kayaal, the decent morals was informed by the ethnic and religious background of a prospective Boy Scout. In other words, the Boy Scout organization's vision of ideal youth with decent morals and proper physical features and health assumed that subjects were able-bodied Turkish Muslim boys. Although the Boy Scouts Charter did not explicitly prohibit non-Muslim boys from joining the Ottoman Boy Scouts, the number of non-Muslim and non-Turkish Boy Scouts would have been extremely low, if not zero, as one can tell from both Kayaal's text and the official charters directly addressing Turkish youth. The admission process and organizational structure of these Ottoman Boy Scout organizations also projected the trajectory of physical and moral eligibility of youth who earned the privilege to be a part of this paramilitary brotherhood. The charter's first article introduces the 5 fundamental segments of Ottoman Boy Scout organizations. Depending on their age, time of admission to the organization, skills and experiences as Boy Scouts, the administrator of the organization assigned boys to one segment, which were all named for ideologically loaded terms that referred to ancient Turkish tribal arrangements. Çeri, Tekin, Alp, and Tarhan were the name of the sections that were used in Ottoman Boy Scout organization. Atsız, which roughly translates as the one with no name, was given to new members. To be promoted to one of the groups that had a higher status, and Atsız had to learn the basic principles of the organization and prove physical ability and loyalty to the cause of the state and nation. One line from the Boy Scouts oath, quote, "I promise to take the heart as my mother, the organization as my mother, the chief of the scouts as my father, and my fellow scouts as my brothers," end quote, exhibits just how much wartime Ottoman Boy Scouting Boy Scouting functioned as a microcosm of the homoaffective bonds that the state aimed to cultivate among its citizens, which was imagined to consist of only male subjects, Turkish Muslim male subjects of the empire. Non-Muslim and non-Turkish youth who were denied from participating in the Ottoman Boy Scouts became part of their communal scout organizations with meaningful eligibility conditions compared to the Ottoman Turkish ones. A Paris-based magazine titled High Scout, Armenian Scout, was the official monthly publication of the Armenian Boy Scout organization founded in 1919 in Paris. The majority of the boys enrolled in the organization were survivors of the Armenian genocide who had fled to Paris. The primary motive of this Paris-based Armenian Boy Scout organization was to rejuvenate the nation by raising physically healthy and strong generations and inculcating a sense of communal belonging in the young Scots' minds and hearts. The monthly publication of the organization thus published many articles on physical health as a significant asset for boys who were becoming men. Although High Scout was a pre-military organization, this was not always at the forefront of how it presented itself. Beginning with the very first issue, published on October 25, 1919, the importance of having a healthy and strong body was broadly stressed for reasons beyond military considerations. High Scout, like other magazines and popular medical journals, also covered athleticism, healthy eating habits, and sexual health. Its emphasis on encouraging young Armenian men to play a sport, not necessarily as a Boy Scout, diverged from the publications and ideological disposition of its Turkish counterpart. The Armenian Scouting magazine did not reduce the definition of ideal masculinity to military heroism, as it was also focused on keeping remaining young population alive and healthy in the face of the genocide Ottoman Armenians had experienced. An article titled "Where to Start and What to Do to Become an Athlete" in the first issue of High Scout reflects its concern with more than promoting a militarized youth culture. The article states that not only Boy Scouts, but every male child from an early age should engage with athleticism, receiving professional training when possible. After a discussion about the benefits of encouraging children and youth to become involved with athleticism, the author addresses the question of who is eligible to be an athlete. Quote, "To receive training in any branch of athleticism, such as long jump, running, pole vault, discus throw, one needs to undergo through a medical examination first. The overall condition of a person's body, as well as their organs, should be observed closely by a medical expert, and the athlete's trainer should listen to the doctor's advice carefully. By doing so, the trainer sees if there is any obstacle that would prevent the athlete's movement, or if there is any need for special training to make their body stronger in order to prepare them for heavy and tiresome athletic games without causing any harm," end quote. Similar to the Ottoman Boy Scouts, the Armenian Boy Scouts also emphasized the importance of physical health and strength as a prerequisite for raising a healthy generation. However, unlike Ottoman Boy Scouts, High Scout promoted the idea that youth and children with physical challenges and disabilities or weak health could be rehabilitated through proper training and supervision. With proper training, even those with physical challenges could become ideal masculine subjects, just like their able-bodied counterparts. Below here is an excerpt from the High Scout athleticism article about quote-unquote weak bodies. Quote, "One should not think that weak ones and invalids cannot exercise or play any sport. In the hands of a good trainer, such boys can also strengthen weak muscles and members. For instance, they can improve their heart rate and the functionality of their lungs through exercising," end quote. From the perspective of High Scout, even quote invalids, end quote, could be transformed into masculine ones, proper masculine subjects with the right form of training, diet, and medical supervision. However, age was a significant indicator of a boy's eligibility to be physically quote-unquote fixed. The age of 16 or above was the ideal age for a boy, Scout or not, to begin athletics. However, this did not mean that boys should not engage in any physical exercise or training before 16. According to the same article, male children's physical development before 16, especially with the start of puberty, happen rapidly. Given the ways in which the author formulated male children's and youth's physical development during childhood, adolescence, and youth, even those with physical challenges could be trained and made and turned into a proper man, end quote. So overall, Boy Scout organizations cultivated a heteromasculine ideal, which was defined at the intersection of gender, health, and national or communal belonging. The different yet overlapping notions of idealized heteromasculine subjectivity held by the two Boy Scout organizations that I introduced during my talk today were shaped under the circumstances of war. Each group defined its version of ideal masculinity according to their political agenda and ideological standpoint. Despite obvious overlaps between the discourses of Turkish and Armenian Boy Scout organizations around ideal and healthy male youth, with emphasis on ethno-religious backgrounds and physical health, both parties held a nuanced understanding of what constituted a healthy body as their approaches to one eligibility to participate in the relevant organization was different from one another. The ways in which such institutions define the ideal masculinity through physical health and the forms of socialization also make them crucial settings, require their analysis beyond their function as military organizations, but as venues that effectively shape young boys' national, gendered, and sexual subjectivity. Thank you so much for your patience, and I'm looking forward to hearing your questions and comments in our Q&A session. Thank you.
Thank you so much, Professor Kayaal. Our third speaker this afternoon is Stephanie Koning. Stephanie Koning is a social epidemiologist and demographer with primary interests in biosocial determinants of women's health and maternal and child health, structural violence, conflict and social stress, and the health implications of migration, displacement, and legal status. She has led or co-led multiple data collection projects using survey, interview, and ethnographic methods, and uses quantitative analytical techniques from biostatistics, machine learning, and quasi-experimental design. Her work focuses on global health and equity or inequity, particularly in North American and Southeast Asian settings. So welcome.
Thank you very much. Just give me a moment to set this up. All right, are people viewing the presenter view or just the slides? If someone can let me know, I can proceed.
I think we can see your view where you have your notes on the side.
Okay, then I'll try to. Okay. Is it any better now? Or is it still?
Will you share your screen again?
Oh, yes. This is always a challenge.
Yes. I think we can still see your notes in a different format. Oh, now we just see your slide.
Just the slide? Okay,
yes.
Wonderful. Thank you for that. Without any further ado, I'll just move a few things around here. First of all, thank you for having me today. My name is Stephanie Koning. As shared in the introduction, I am a social epidemiologist and population health scientist, and currently a postdoctoral fellow at Northwestern's Institute for Policy Research and Department of Anthropology. As many in this current space are already well aware, violence operates through social, structural, and personal channels of influence, affecting over 1 in 3 women globally, having forcibly displaced over 1% of the world's population, and it contributes to inequitably disparate lived environments and experiences. Yet how it's embodied and gets under the skin to affect individual and ultimately population health often remains unclear. To that end, I study the acute case of historical and ongoing organized violence affecting cross-border populations in northern Thailand, neighboring Myanmar, also known as Burma. I should say neighboring Burma, also known as Myanmar. Relative to many of the outstanding scholars here today, my efforts to better document and uncover health consequences of organized and structural violence is in many ways a relatively simple objective, yet remains extremely challenging given current data and norms for population health research, my primary discipline. Informed by a year of ethnographic fieldwork and a novel sampling frame I developed for displacement affected populations at the border, I ultimately designed and deployed a survey of violence and health to look at this, to look at violence and health over the life course among 824 mother-child pairs in 2016 and 17, comprising interviews, health assessments, and biomarker data collection. Key contributions include uncovering systematic chains of violence against women in different migration and displacement flows or movements, reproductive health implications of human rights, human rights violations at conflict borders, and new methodological insights for studying the role of violence in migration and health research. Today, I will share more background on this context, describe the data collection process, and highlight some key new findings, which are still preliminary, and discuss priorities moving forward, including some of my ongoing work to address these priorities. To give you a little more background on myself, I've worked in Thailand now for the past 14 years, including 5 years of in-country field research. My interest in health in northern Thailand began as a volunteer with a grassroots health organization, then with the United Nations, and more recently in academic settings. I have primarily worked with women living near the border with Burma. Some belong to indigenous communities that have historically lived on both sides of the border for generations. Some live on work sites and some in makeshift refugee camps after fleeing military fighting in eastern Burma that has lasted over 60 years. When talking with women, worries about 2 things often come up: legal status and the ongoing fighting directly across the border. Many are stateless, meaning they are not recognized as citizens of any country, including Thailand, even if they were born there. Others worry about having fled the fighting in Burma, but not being recognized as refugees. This means they are at risk of being sent back to Burma or repatriated. Because legal status documentation is hard to get in Thailand, even people born there are worried about being deported. The women I have met also remain resilient, yet still burdened by stress and chronic illness. Thus, I have devoted much of my ongoing research to better understanding social and biological or social biological determinants of health tied to women's life course experiences of violence and stress, especially since even among women who left Burma, experiences at the border vary substantially. This approach really aligns with the life course framework for studying how we carry stressful experiences with us over time in our bodies. First, starting with early life health, we know that some positive stressors help with development, while other stressors are more negative and require greater support. Some stressors are much harder to overcome. These are called toxic stressors and often occur in clusters, involving violence, neglect, and/or chaos. These are common in war and other unstable environments. Today, I will focus on specific types of violent contexts at the border in which women face the dual burden of past trauma and ongoing societal violence and related stress, resulting in life course patterns of experience and stress that they ultimately embody. In Myanmar, women and families have been fleeing armed conflict in a failed state for over half a century, embarking on perilous journeys to reach the mountainous border region of northern Thailand. Myanmar has ranked in the top 10 major source countries for refugees worldwide since 2009. In 2019 alone, an estimated 1.1 million civilians were displaced from Myanmar, including over 97,000 displaced to Thailand. As is the case for the majority of the world's displaced, affected groups remain concentrated near the border. As shown in yellow on this map, displacement is concentrated in eastern Myanmar, with camps as red squares dotted along the border here. Some of these have even been discontinued in just the last 5 years. The Shan state, bordering the northernmost region of Thailand, has been one of the most severely affected ethnic states by the Burmese military's oppressive strategies. The Shan state is pictured right here. This map is of all of Burma or Myanmar and presents regions with more concentrated outmigration to Thailand in darker orange, including the Shan state right here. And this is where I focus my research. We already know that armed conflict exacerbates gender-based violence, which was most thoroughly documented in the context of the Shan state in License to Rape, an unprecedented report put out by the Shan Women's Action Network, with Chum Tong, one of the co-founders, pictured here, presenting to the United Nations. This report showed how widespread use of violence against women was being used as a military tactic used against civilian populations. Upon fleeing violent conflict, women and families arrive in Thailand to a new structurally violent landscape that does not officially recognize refugees and where ethnic minorities have historically been marginalized and excluded from citizenship and related human rights protections. Refugee designation has been implemented in an ad hoc manner, meaning some individuals end up in poorly resourced camps for decades, and others move into villages or employer-managed work sites such as agricultural fields and temporary construction sites or domestic work in homes. And this situation, this variable destination kind of situation in Thailand is due to Thailand not being a signatory to the 1951 Refugee Convention, or it's related to this phenomenon. Thailand generally treats everyone as temporary migrants by law, making many without adequate paperwork subject to arrest, detention, or deportation. Meanwhile, paperwork poses its own challenges due to high costs and fears of repatriation when people enter the registration system. As a result, many ethnic minorities in northern Thailand get lumped together into categories of migrant that are subject to social discrimination and few legal protections, creating overlapping patterns of marginalization and threat among groups and individuals with distinctly different histories of lived experiences. As I began my most recent study at the border, it remained unclear how violence against women and related human rights violations were both widespread and patterned by different histories. Returning to the life course approach to patterns of stress, there are ways in which distinct patterns in past and present stressors may produce different health outcomes that are important. For instance, past experiences of having a neighbor's home destroyed or ongoing risks of deportation can contribute to heightened anxiety, vigilance, and other forms of stress hyperactivity. Meanwhile, chronically oppressive military occupation in Burma or isolation in protected refugee camps in Thailand can produce symptoms of depression, burnout, and other blunted or hypoactivity of stress responses. Yet it remains unclear when and how these different outcomes occur. And this is just one example with mental health symptoms that could also be seen in metabolic processes and other aspects of health and function. So to better understand how legacies of violence and ongoing human rights violations were affecting women and future family health at the border, I designed the Thai-Myanmar border maternal and child health study. Study objectives fall under two broad aims. First, how does violence across women's life histories structure, and how is it structured by migration experiences? And how do legacies of violence and ongoing human rights violations affect health, including whether ongoing situations in Thailand are potentially making things better or worse? And I'll just briefly touch on some findings from both. First, let me explain a few aspects of the study design. I trained and led a local team of researchers to conduct a population-based survey of recent mothers at 2 border sites in northern Thailand in 2016 to 17. Very few, if any, prior studies had created sampling frames anywhere designed to be population-based studies of areas with concentrated migration and displacement occurring both or represented both in and outside of official camps and legal migrant registries in this way. Over a year of preparatory ethnographic study and field testing went into selecting field sites, designing the sampling frame, developing and translating the materials, and training interviewers. Ultimately, with the help of over 25 trained team members, we completed standardized questionnaire-based interviews and/or health assessments for 824 women with completely linked data for 577 women. With limited time, I'll jump straight into the results now on links we uncovered between past and present stressors and violent stimuli that women encountered and how they were also violently structured. And what I mean by this is how women's historical and ongoing experience of violence are not random, but are systematically patterned within and across women. So first, if we think of historical and present context separately, here represented in colored bands on the left and right, and conceptualize these, for instance, as pre and post-migration or displacement context, we can then trace flows from more and less violent contexts over time. The groups represented in these bands, which I'll reveal in a moment, here are based on life event profiles created from life event inventories used in questionnaire-based interviews. With more violent contexts, we'll see in a minute, located near the bottom, and less violent context located at the top. Then here I visualize how women travel through context over time, just with this one split between pre and post displacement, and women born in Thailand were also represented in the sample, and they're located up here. And we see more descriptive labels also here for historical exposure to migration and military-based violence on the left, and more minimized and severe threats living in Thailand near the border on the right. When I then model the odds of ending up in a high threat environment on the lower right side, this was defined by personal security and safety, threatening events or risk factors. When we look at odds of ending up in this kind of context among women interviewed, conditional on historical violence, we see that women that have been displaced due to the most severe forms of military violence are at the highest risk of chronic violence and related stressors later in life. Now, how do these life course exposures affect women's health? Returning to the expectation that certain acute life events would contribute to generalized anxiety long-term, I'm starting to map symptoms of anxiety and other mental health disorders onto these flows of violence and displacement. Here you can see an evident gradient in higher levels of anxiety in darker orange, following higher levels of violence near the bottom of the screen. I am similarly analyzing depressive symptoms, finding evidence of greater depression similarly tied to historic violence and both livelihood and security threats at the border. It's also important to acknowledge that self-reported symptoms are limited by subjective reference points and remaining social stigma around mental illness. We also collected women's hair to ascertain whether and how biomarkers of stress map onto life course experiences. Just as anxiety and depression present in distinctly different symptoms, prior research with hair cortisol suggests that exceptionally high or low cortisol is indicative of maladaptive stress responses. And we see here evidence of a blunted cortisol stress response among women chronically exposed to greater violence at the bottom, with outcomes varying among some subgroups of women that move between contexts. And these findings remain preliminary. I am still actively investigating sources of variation and trying to better explain what's going on here. To summarize findings, chains of violence against women emerge in different life course patterns of movement, often missed in population and health research due to omissions and erasures in population counting and measurement of lived experiences. And violence is a dynamic and systematic exposure over the life course. Many of us in this space know that already, but it still doesn't get quantitatively documented in the most effective or informative ways. And these aspects of violence must be acknowledged and studied as more foundational to public health promotion and population health research. Historical and ongoing violence produce what has been called a long echo of women's health and stress consequences that are still surfacing in current global health scholarship. And I know I'm over, but just to briefly touch on next steps and future priorities, to go a step further, here clearly more needs to be done regarding how to address trauma related to past and present violence against women. While this is already broadly recognized, there's more to be done in the fields of public health and population research to document what is occurring and how to promote better structural reform and empowerment to make the violence stop. I continue to work with community-based partners, local scholars, the UN, and colleagues here at Michigan even on how women need and want to see changes. Second, more needs to be done to develop and transfer methods for studying these phenomena on a wider scale while maintaining high standards for ethical, context-specific, and culturally informed methods. I didn't go into the exact methodology today very well, but I would love to talk with any interested individuals on that more in the future. This is a particular area of interest in my own work, and I think I'm always marveling at my colleagues who are ethnographers and doing interviews that help and historical analyses to help inform how we can better document things on a wider scale. Third, more needs to be done to expose and further investigate the intergenerational impacts on families and populations. And this is really where this survey and ongoing data collection will be focused on. How are these experiences of women being potentially passed on to their children and their families in ways that we can further support women and counteract the adverse effects of historical violence and intergenerational trauma. Again, this just scratches the surface of answering the question of how we can respond, but I'm inspired by the work of you all here, and I look forward to talking more with and discussing this in the Q&A session. Thank you again, and I will close with a special thanks to many other colleagues that have made this work possible, including the names of many research assistants and partners that I leave unnamed here just due to the public dissemination of this video potentially, but they have been so critical for this work to happen. Thanks.
Thank you so much, Dr. Koning, and I'm glad that you are nearby, and hopefully I can reach out and talk to you much more, as I'm sure lots of our participants will want to do. We have so much information about intergenerational trauma on populations in the United States, and it's this is the first time I'm seeing this kind of biological research connected to the social histories outside of the context I know here in North America. So I'm excited about that. Our final speaker is Kasia Klasa. Kasia Klasa is a PhD candidate in health services, organization, and policy at the University of Michigan School of Public Health in the Department of Health Management and Policy. Broadly, her interests lie at the intersection of public health, risk resilience, and politics. She uses mixed methods to compare health policies and politics across high and middle income countries, drawing from cross-disciplinary training in nursing, healthcare management, public health, economics, and political science. She received her master's in public health and global health management and policy from the University of Michigan, and a bachelor in science in economics and bachelor in science in nursing from the University of Pennsylvania. So welcome.
Thank you so much. Let me share my screen. Does everyone see the regular presentation, or is it the presenter view?
It looks like the slides we're supposed to see.
Okay, awesome. Let me. So last speaker of the day, so I'll try to be quick and brief and not go over. Thank you so much for the opportunity to present and give this talk, and thank you to all of the wonderful speakers before me. I think that by now, everyone knows that the COVID-19 pandemic was a shock to not only health systems around the world, but economic, social, and even political systems, that it has led to a series of cascading effects felt over a year since its onset. In this talk, I'll discuss the evolution of the COVID-19 pandemic in Central and Eastern Europe, focusing on the pandemic's impacts on healthcare workers and migrant workers. Central and Eastern Europe is a vast and politically, economically, and culturally heterogeneous area that has uncertain, often contested borders. Broadly, it extends from Germany to Russia, and in some definitions beyond. Additionally, it includes countries that are members of the European Union, EU candidate countries, and non-EU countries. While diverse, Central Eastern European countries face similar challenges and are intricately interconnected with each other and the rest of Europe. To frame the COVID-19 pandemic, let me briefly go over a few key distinctive features of the region. First, many of the countries have similar socio-political historical contexts. CEE countries were communist states at some point prior to the early 1990s. Politically, most have transitioned into democracies, but such governance transitions were not always smooth. Recently, there's been a rise in populism across the region, which has tested their democratic institutions. While CEE has vastly heterogeneous cultures and ethnicities, there is a strong sense of nationalism within each country throughout the region. Religion is also important. Some countries are predominantly atheist, potentially a remnant of state atheism during communist rule, while others view their religion as intricately tied to their cultural and ethnic heritage, for example, Roman Catholicism in Poland. Socio-political urban-rural divides are also quite common. Urban areas tend to be more liberal, younger, and more college-educated. Rural areas tend to be more religious, have fewer college-educated individuals, vote for right-wing or populist politicians, and follow traditional norms that skew conservative, for example, patriarchal gender roles with the female mother homemaker and the male breadwinner. Because of the time constraints of this presentation, I will only be briefly focusing on 3 case countries: Poland, an EU member state, Serbia, an EU candidate state, and Ukraine, a non-EU state. Poland has experienced 3 major COVID-19 surges. It had a good initial response to the pandemic because of its swift border closures and implementation of strict social distancing measures. This led to low initial infections and deaths. However, by the second wave, Poland had one of the highest cumulative excess mortality rates in Europe. Deaths in October to December 2020 were approximately 40% higher than in prior years. Deaths in the third wave, April 2021, were almost 50% higher. So what caused this? There's no single cause in Poland, or for that matter, in any of my 3 case countries, but there are many factors that could have contributed to such an outcome. One reason could be Poland's low COVID-19 testing rate. Policies, politics, and barriers to testing led to undercounts of COVID-19 cases, allowing asymptomatic individuals to continue to unintentionally spread the virus throughout the community. Free testing was initially difficult to access, with individuals required to have both a consultation and referral from a doctor. Private testing clinics charged steep out-of-pocket prices, making them mostly used by international visitors. Such barriers to access were paired with generous sick leave policies, which incentivized quarantine without a clinical diagnosis, especially in households with at least one COVID-positive individual. Additionally, elderly Poles have some of the highest rates of chronic disease in the EU. Despite overall decreases in personal mobility due to a strict national lockdown in March 2020, the elderly, low-income, and migrant individuals still heavily relied on public transit. They continued to use buses, light rail, and trains with minimal social distancing enforcement. Policy stringency also varied greatly at the subnational level. The reasons go on, from limited restrictions being placed on the Catholic Church to the passage of strict anti-abortion laws that led to nationwide protests. But perhaps more importantly, Poland's, and for that matter, all of the case countries, public health and healthcare system has been historically underfunded. The COVID-19 pandemic overburdened its strained health system. A lack of healthcare staff was one of the biggest bottlenecks to pandemic response in Poland. It has one of the lowest number of doctors and nurses per capita in the EU. Additionally, due to poor routine testing, most cases were only confirmed during screening in emergency rooms, leading to the closures of hospital wards and quarantining of healthcare staff. There was limited access to specialty care, diagnostic procedures, surgical operations, and even primary care physicians. Many patients had to delay preventative care and elective or scheduled procedures, even for life-threatening illnesses. While the number of COVID-19 patients increased throughout 2020 and into 2021, the number of healthcare workers didn't. Already prior to the pandemic, many doctors and nurses chose to emigrate abroad in search of better opportunities, such as higher pay, particularly in Western Europe. Current healthcare spending is low, which makes it challenging to retain old or attract new healthcare workers. Furthermore, Poland's summer 2020 presidential election encouraged heavy politicization of the virus, leading to mass public skepticism. Many medical professionals felt ignored, threatened, and unsupported, which led to high rates of burnout, mental health crises, and early retirements among older workers. To put things into context a bit, early in the pandemic, about 1/6 of all confirmed infections occurred in healthcare workers. To partially address this shortage, Poland passed laws to increase its supply of medical professionals from surrounding Eastern European countries, mostly from the Ukraine and from non-licensed providers such as nuns, potentially contributing to brain drain from countries with even fewer healthcare resources. Moreover, migrant workers in Poland were disproportionately negatively impacted. With one of the highest non-EU migrant employment rates, Poland relies heavily on seasonal migrant labor in the agricultural, manufacturing, service, and long-term care sectors. Migrant workers are essential to the country's economic stability, and the pandemic greatly impacted migrant workers' personal economic stability due to their reliance on employers for housing. Most migrant workers are men between the ages of 25 and 44, and they come from Ukraine, Belarus, but with a growing number from Asia. Early in the pandemic, many individuals returned to their home countries, which devastated the agricultural industry. However, many still stayed despite unstable conditions because of fears of not being able to re-enter later on. In 2021, demand for foreign labor increased as migrant workers returned in mass. Additionally, Polish nationals themselves are often low and medium-skilled job migrant workers in wealthier EU countries. They fill critical labor needs in agriculture, construction, manufacturing, and transportation throughout Western Europe. Next, I'll transition to an overview of Ukraine, which, unlike Poland, is not part of the EU and does not receive the benefits and perks of being in it. It is a lower middle-income country that has faced political and economic strife, particularly due to active violence with Russian separatists in its eastern conflict zone. The pandemic has only heightened these tensions. Additionally, it has also had a weak and underfunded public health and healthcare system. Excess mortality in government-controlled areas of Ukraine remained near the average for Europe until recently, this late summer and early fall 2021, when it saw the biggest surges in cases to date. Despite Ukraine locking down early, it relaxed restrictions quickly. The true magnitude of its prior surges and this most current surge is likely to be greater than case counts even indicate. Limiting testing capacity means that not all cases are being counted. Ukraine's testing is at a rate below that of Poland, Romania, Russia, and far below the rate of other countries such as Czechia, Latvia, and Estonia. In April 2020, Ukraine had planned a second phase of health policy reform, which would have led to the dismissal of 50,000 doctors and the closure of 332 hospitals. However, the government reversed this decision to preserve health system capacity. Nonetheless, its health system still presents at a lower capacity than EU health systems, and each surge is stressing its underfunded and urban-centric hospital system more and more. Additionally, Ukraine has fewer specialists than Poland, with many of them leaving the country for better pay and opportunities. From physicians and nurses to ambulance crews, healthcare workers also faced increased workloads, decreased benefits, such as less time off, and inadequate wages. Bonuses to healthcare workers were not distributed fairly, with higher bonuses often given to male-dominated fields such as doctors, despite women making up the majority of the workforce in healthcare. Additionally, despite unsafe working conditions, such as a lack of PPE, healthcare workers were not allowed to claim workers' rights compensations if they were infected with COVID-19 on the job. Ukrainians make up the largest group of labor migrants in the EU. About 13 to 16% of Ukrainians, or 3 million, work and live abroad. Most emigrate to Poland, with the rest predominantly going to Italy, Czechia, and Russia. The vast majority, 70%, as mentioned, are men between 30 and 50 years old that come from rural areas in the western part of the country. They tend to be low to medium skilled workers and send much of the money they earn back home, where remittances account for 10% of Ukraine's GDP. Many migrant workers travel for regular short-term jobs that last less than 3 months because of visa-free regime legislation. Many workers don't sign contracts, are paid in cash to avoid taxes, and often rely entirely on their employers for housing and transportation. Ukraine's significant migration in labor was substantially curtailed in September 2020, which impacted EU countries that heavily rely on Ukrainian migrant laborers. Third, we'll talk about Serbia, an EU candidate country in the Western Balkans that has received fewer benefits from the EU than Poland, but more than Ukraine. Like the other two case countries, excess mortality in Serbia was relatively low until late winter of 2020, but it increased significantly. A strict lockdown was implemented in the early stages of the pandemic that included curfews and bans on movement. But these stringent measures were relaxed by the summer of 2020, making Serbia one of the first countries in Europe to again allow mass gatherings. Critics blamed the government for lifting restrictions too early because of scheduled parliamentary elections that were to occur in June 2020. Mobility returned to normal and society reverted to pre-pandemic behaviors, which could have contributed to the high number of cases and deaths seen later in 2020. Officially, Serbia requires individuals to wear a mask indoors and social distance, but there's little or no enforcement of these rules. These rules are individuals' choices, which has led Serbia to currently, as of last month, face its worst surge to date. Serbia has limited public health and healthcare capacity to fully address the significant surges in cases. Although healthcare capacity is limited in rural areas, they have tried to mitigate the pressure on their health system by constructing multiple vaccine clinics and temporary hospitals. Additionally, Serbia did receive monetary support from the EU to mitigate the health system pressures they faced. More recently, Serbia has turned into a medical tourism hub for Russians seeking Western vaccines, such as the Pfizer vaccine, so they can easily travel to more countries, as Sputnik is not on many approved vaccine lists. Serbia has an unequal distribution of healthcare workers with many shortages in specific specialties, such as surgeons, anesthesiologists, and radiation oncologists. Additionally, the country has no official workforce strategy. What this means is that many younger healthcare workers, such as physicians, are unemployed and often leave the country to work abroad for higher pay. Most medical staff ends up being concentrated in urban areas within universities and specialized medical centers. The pandemic strained and overburdened this health system and these healthcare hospital systems in urban areas. Additionally, the government's decision to lift social distancing policies faced fierce backlash from healthcare professionals themselves, who actively and openly criticized the country's poor management of the public health crisis. Many healthcare workers additionally questioned official statistics that were being released in summer 2020 about COVID-19 infections and deaths. These were later found to be underreported during the time that the Serbian Progressive Party was holding its elections. This led to mass protests across Serbia, which ended in a few violent crashes in its capital. Serbia is also a major passing point for migrants from the Middle East to Europe. Since 2015, the number of refugees and migrants has grown after Serbia became a central passing point to the EU for people coming from countries facing civil and political unrest in the Middle East, Central Asia, and Turkey. In 2020, it's estimated that more than 60,000 people passed through migrant reception and asylum centers. The COVID-19 pandemic led to increased lockdown measures, which led to pushbacks amongst refugees and migrants who were left in a silent limbo, causing a growth in informal migrant camps. Many migrants were left estranged throughout Serbia, Bosnia, Macedonia, and Bulgaria. Additionally, Serbia's Roma population are particularly vulnerable minorities when it comes to COVID-19 due to a lack of access to proper sanitation, PPE, and technology facilitating public health communication and vaccine registration. Poor and unstable housing conditions, such as a lack of running water in many Roma settlements, places them at a higher risk for COVID-19 transmission and infection. Both these groups of individuals have high hesitancy around vaccines as it's related to the low trust in government that they have. As vaccination efforts continue to expand, issues of equity in regard to the Roma population and migrant populations will be critical to address. So how does all of this relate to gender and health? How does gender and health intersect during this unprecedented historic event? Women make up the majority of healthcare workers globally, but especially so in Central and Eastern Europe. In Poland, over 80% of healthcare and social services workforce is female. While the gender pay gap in Poland is one of the lowest in the OECD, young women in Poland are actually more likely to have a university degree than young men, but paid similar salaries. They're less likely to hold C-suite and high-level executive positions. Healthcare workers have tirelessly advocated for higher wages this last year, better working conditions, greater investments in the country's healthcare system and infrastructure, but they've often been ignored by politicians and policymakers, both male-dominated professions. During the pandemic, the female-dominant healthcare workers had to put a lot of time and many grueling hours into serving the population, and many even saw their civil rights deteriorated with the passage of highly restrictive abortion laws, which sparked a wave of civic engagement and grassroots protests throughout the country. Women have become an important pillar of the Polish economy, but often their voices fall on deaf ears during the policymaking process. Additionally, while most migrant workers are men, the majority of migrant workers in service jobs like informal care, childcare, and especially long-term care are women. These female migrant workers are often ignored, but they contribute important labor, they help fill important labor shortages in long-term care throughout Poland and Western Europe. These jobs have less stable contracts, lower pay, and many women are heavily dependent upon the host family for housing and support. This puts many female migrant workers in vulnerable situations. Additionally, migrant workers are important targets for vaccination as they work high-risk jobs and cross national borders, but only about 1 in 3 in Poland have advocated or said that they want vaccination. So far, less than 1% of migrant workers are vaccinated, despite being legally entitled to free vaccination. In the Ukraine, similar trends exist. Women make up over 83% of the healthcare workforce. Their salaries are often below the national average, and many face unsafe and unhealthy working conditions. Additionally, Women face increased burdens of unpaid work due to additional caring responsibility fueled by traditional gender roles, particularly when the care and education services were shut down last year. Despite all of these obstacles, healthcare workers fought and petitioned existing healthcare trade unions to ensure better conditions. The country saw increased civic engagement among healthcare workers and a growing movement to protect labor rights and decrease the gender pay gap. The same can be said in Serbia, where women also make up the vast majority of the healthcare workforce, 76.5%. There, they have also been disproportionately affected by the pandemic. They face gender inequality in pay and in unpaid work, similarly to patriarchal attitudes and stereotypes in society and professional life. They had to juggle multiple responsibilities, such as being caretakers for both older patients and younger children, stifling and limiting their ability to advance their careers. The pandemic brought to the spotlight the gendered inequalities that exist in political, economic, and health systems throughout Eastern Europe. It also highlighted the exclusion of healthcare workers in the policymaking process. Particularly, it highlighted the absence of female voices, who are often the frontline workers that deliver public healthcare, global healthcare, and all healthcare services in designing and leading the COVID-19 response. As has been summarized in prior research, women deliver care, men lead care. But regardless, many workers embraced collective action and chose to use democratic institutions to fight for their and their patients' rights. Hopefully.
Wow.
That was a mouthful. Try to keep
that
it on time.
that was a lot to take in. And certainly really thinking about how feminine the healthcare services are in this part of the world, which genders the COVID response in a different way than maybe here in the US, where the healthcare workers are not, don't skew as far toward being so female. I am happy to say we have lots of time for questions. So I am going to look in my question and answer section to see what we might have, and also open to panelists who might have questions for each other. There are so many ways that across these talks, sorry, that's my timer. We were talking about gendered ways that we understand. I'm going to call it, broadly speaking, sometimes reproductive work and productive work. And when I say reproductive, I mean not just creating babies and being pregnant, but all of the being a healthcare worker, working in long-term care, all of the things that we do to produce people who do productive work, and then how I think not that all of you were talking about COVID, but COVID has certainly revealed how important that side of life is. Again, maybe in the past we were more aware of that. In agrarian times, we could all see it, and then capitalism has made it invisible for a while, and then COVID sort of revealed it again. But we're talking here about so many of the gendered ways that we approach parts of life, whether it's war and soldiers, made through small boys' bodies, or healthcare workers. So I have many places I could start, but what if we, I want to say, Yiming, I was really interested in that piece, that slide you had about the reproductive health and versus like the language around the skeletons. And could you just say, were you looking at the language around the skeleton and pointing out how gendered it was, that they were talking about the bones? Could you just say maybe a little bit more about that, the way that they were talking about those, the skeleton through that very gendered language of the life course?
Yeah, thank you for your question. Because this is a long book, I first read the first part and the last part, and I want to see that because the skeleton is this dissection, the core of this dissection-based anatomy. So I think generally speaking, it depicts most part of the skeleton in ungendered ways, but all the gender difference of the skeleton is based on the reproductive function of women. And I think in its serialization in 19th century, after women got into their old age, their skeleton even lost its distinction from men. So I'm thinking I just think it's very interesting to say how it perceives the gender difference based on reproductivity.
Yes, that was a fascinating little snippet or a view into that. I've recently read about the way that we talk about ancient bones that we find, pelvis, and why we think that they're male or female. It's very fascinating. I would also ask panelists if you saw things in the other talks that speak to your work.
Yes.
Go ahead.
I have a quick question for Professor Kayaal. I'm not sure whether I pronounced right. I'm sorry. Yeah, I think you mentioned about the bodies of their young boys. And I know that because in my project, one of my projects that I deal with nation and masculinities in modern China. And I know that in many of the propaganda posters, the nation or the state was embodied or personified as man, no matter weak or strong. But I think mostly in my case, they are adult men, at least in their 20s or 30s. And I'm thinking in the Ottoman Empire's case, does the empire also personified as a man? And if a man, what kind of body the nation had? And so is there a lineage of different stages of male's body in this long lineal development?
Thank you so much. This is a wonderful question, actually. So about also especially in the early 20th century with the Balkan Wars, but particularly during World War I, the Ottoman Empire also, especially when we look at the humanitarian aid organizations, propaganda postcards and posters, they, in some cases, use male soldier body to kind of create this sense of patriotism, especially among youth, to kind of set up this ideal example. But when we look at the children's literature and especially the advice manuals, which I mostly use in my advice manuals and different kind of literature that I mostly use in my project, they use the body of young Turkish Muslim boys, mostly adolescents and children, because especially the national imagination, they represent the future of the nation. But of course, this is not unique to the Ottoman case. I mean, when we look at the Great Britain, India, and also in China too, I mean, I'm sure there are some references to young male body and the energy, like this kind of certain physical attributes represented through it. It has some implications in the national imagination. So especially in the early 20th century, during the late Ottoman Empire and the Republic of Turkey, the young male body, it particularly represented the power and this visual imagination of the nation. So yeah, I mean, age, adolescence, and childhood was particularly, I mean, the Ottoman state was particularly obsessed with deploying child's body as this, national ideal and the representation of nation.
Yeah, thank you so much.
Of course, thank you.
with those two talks juxtaposed, looking at refugees and then looking at Central and Eastern Europe and talking so much about the migrant workers and seeing these two populations that are so invisible to most of us most of the time, and thinking about the ways that you're trying to make them more visible, or they're, how do we count these bodies? How do they become, the statistic that less than 1% of migrant workers are vaccinated is amazing. So I don't know if you felt that there were ways that these populations, that the ways that you're studying them, how do we make health issues at for these most vulnerable populations become more visible?
Yes, so that's something I wish I had time to, touch on more in the presentation, but a part of it has to also deal with the fact that Eastern Europe has this shared history, but kind of they've evolved and progressed at different rates. And some of that has to do with, for example, Poland being in the European Union and the European Union having this tons of wealth and money and support. I'll explain it in terms of vaccinations, in particular in terms of accessing vaccines. Poland was allowed to be in those negotiations and they had a seat at the table and were able to actually petition for more vaccines and get vaccines and vaccinate their population much faster. And in terms of vaccines, they were able to get, you could say, more Western vaccines, Pfizer, Moderna, AstraZeneca, Johnson & Johnson. Versus Ukraine and Serbia, they have very different, similar but very different histories. They don't necessarily have access to the European Union. They were not able to negotiate. They were often ignored to the detriment of Western Europe. Most migrant workers were ignored, and Western Europe's feeling the negative impacts of that now, with a lack of truck drivers, a lack of agricultural workers, just a lack of all these essential workers that they just took for granted. And Poland felt that as well, with a lot of individuals going back to the Ukraine. And now a lot of these migrant workers realizing how critical they are to labor, not wanting to accept such low wages, trying to have collective action and leverage to bargain for more rights, for better work environments. But Serbia and Ukraine, for example, they were also heavily influenced by Russia and China. Those were the countries that reached out to them more. Europe ignored them. They got Sputnik, vaccines very easily. There's also a lot of distrust in the government and distrust in Western Europe, just distrust in vaccines from the Soviet era occupation, communist rule. And you see this division in terms of vaccine rates now, where Poland did manage to vaccinate its population and has an active vaccine program, and places like Ukraine and Serbia are having awful surges now because vaccine uptake is very low. The vaccines they're getting are not adequate enough to vaccinate the entire country. And quite frankly, I think Western Europe or the EU still not addressing these concerns. And that's where discussions about whether we should give booster shots or not have been coming in, where Western Europe and the US is actively promoting booster shots, and they may or may not be important, but we are ignoring large parts of the world that haven't even had a first vaccine, but pretty much are all of the essential workers that we rely on for food, for logistics, supply chain, everything, manufacturing, warehouse, making your shirts or your furniture, etc. And and this is kind of like this greater, I guess, political dynamics that are happening there. So it's interesting, and even within the EU, like Poland is definitely on the lower end of the totem pole sometimes, and that adds very interesting tension in the country and outside. But yeah, it's also really palpable in terms of migrant workers to notice that like female migrant workers are even more ignored than male migrant workers, where many individuals don't even know what female migrant workers do, how they contribute to the workforce. In particular, I'll use Poland as an example. Female migrant workers from the Ukraine pretty much are the #1 informal care workers in long-term care, home health aid. A lot of individuals that leave Poland and earn, work in the US, work in Western Europe, they hire Ukrainian women to take care of their parents, etc., because the healthcare infrastructure isn't very robust. But these women often live in the apartments with the family they're taking care of. They're dependent heavily on, the salaries. That's their form of housing. So if an individual dies, or if a family just doesn't like a particular worker, they can fire them, and they pretty much could potentially be homeless until they find another job. So the same holds true for refugees and migrants in Serbia and a bit in the Ukraine. Women are often ignored. They could be subject to sexual violence, which you don't necessarily hear about. Oftentimes they don't really have a voice, and you just don't see them in media photos at all. They're kind of like just missing. So these individuals, like migrants, they travel back and forth, and I think it's coupled with like fear of being deported, fear of losing their job. There's also maybe a language barrier and gap, and limited, I guess, motivation to even produce public health materials in many languages and outreach programs. I know for a long time in Poland, they actually didn't have anything written in Ukrainian throughout the pandemic, no outreach material, nothing. And it took them a while to build that up. So a lot of individuals who were from Ukraine working in Poland that didn't know how to speak Polish had no idea really what was going on, didn't realize that they were at risk for COVID. And this kind of is this cascading negative cycle where there's just more and more distrust, compounded by social media and misinformation, etc. So I think it's a global effort, and it will require a lot of countries working together to make sure that every individual has access to a vaccine and is informed, and can be vaccinated in the long run.
Stephanie, this is a very kind of specific question, but do the refugees where you were working, you said that some of them are in refugee camps that are more formal and others are more integrated into the community. And do they consider themselves refugees, or do they consider themselves migrant workers now?
That's a great question. Yeah, so with Thailand's kind of ad hoc policy relative to different groups who have fled Myanmar at different times, they are not consistently recognized as refugees, as mentioned, and there's not a consistent kind of channel for even processing asylum seeker claims that is uniform across different parts of the border and for different people groups that have fled different areas within Myanmar. So the Shan state is one area that Thailand has been more reluctant or resistant to recognizing individuals leaving the Shan state of any ethnic group to come to Thailand, and that was based on some different political maneuvers and agreements with the Burmese government, and that has led to just one single informal camp that borders the Shan state relative to many more that border, for instance, the Karen state. And so there is one there. It receives humanitarian aid, but it's only recognized as temporary shelter by the Thai government. So UNHCR isn't even really granted special access to this camp. So in many ways, it's just still not official. But then in addition to that, there are individuals that have fled and not ended up in that camp. There's also families now, since that camp was initially established over 10 years ago, there are individuals who were born there or who originally went there and have chosen to voluntarily leave, even though they don't have legal documentation to work elsewhere in Thailand or even to live elsewhere. They're willing to kind of take that risk because the camp is so under-resourced and doesn't have much regulation. So yes, the short answer to your question is that there are many people that are not in the camp that still identify as asylum seekers. There are also individuals who, if you question them on why they came to Thailand, they may not give the conflict or soldiers as their first reason. However, if you start asking about exposures to different situations in Myanmar, you find that there is a blurring of lines, even in people's own recognition of, what rights they might have or how they might actually be able to identify as an asylum seeker. And I think that is a product, probably in part, at least by living in a context that's all they know. They're not like asylum seeking isn't really recognized or advocated. Well, it's advocated for, but it's just not used in the language in the same way because it doesn't have as much meaning when it's not recognized by the authorities. So yeah, that we did ask just an open-ended question about reason for leaving or for coming to Thailand, in addition to all of these yes or no questions about things that they've experienced. And I'm still trying to unpack what it means when individuals don't list violence or war as the reason why they left, and yet they report these exposures or experiences that definitely align with fleeing conflict.
And your focus was on recent mothers, was that true?
Yes.
Out of curiosity, so if a lot of them are at that camp, do they have access to traditional birth attendants, or who's providing prenatal care and labor care?
Yeah, that's a great question. There is a health clinic located in the camp. And again, many women in the survey were not living in the camp. And that camp offers facilitation of seeking services, but it's not fully equipped to provide like obstetric care, for instance, and prenatal care visits. I think it's still recommended that someone from this clinic help take them to an outside clinic to seek services. And with that facilitator, they are legally able to go. But I think because of the current circumstances and the mobility of the communities that I worked with, there are not as many recognized traditional birth attendants as there were historically, or that as there still are within the Shan state, although that has been that's been affected by the conflict as well. There are definitely trained healthcare workers inside of conflict areas inside of Myanmar that are trained from outside service provider or NGOs and other groups like women's networks that are focused on training midwives and people that can facilitate community-based healthcare. But yeah, I think a lot of that cultural norm and structure around midwifery and traditional birth attendance has been definitely burdened by mobility and the disruption of these communities.
Gabriel, will you give us a time check? How are we doing? Okay. I could ask you lots more questions specifically about that, because that's like my favorite thing to talk about. So another time, I'd love to hear more about it. I think that where a person gives birth and with whom just has so much to do with that trauma experience, and can be healing of trauma or re-inscribing more. Let me open up. We have a lot of participants, and if there are any questions out there to our panelists, things that you wish that you could hear more about, or panelists to each other. I do know it's the end of a long day. A great day, very packed, but when you get that much intellectual activity compressed into 15 minutes, it's actually very dense and hard to like, it's tiring to try to process so much, because this represents years of your work condensed into 15 minutes. So even for us to process it, it takes a while to chew on it all. I think that I'd love to make sure that you all can find each other in the future, that anyone who's here watching can find, write down the names of these folks and their institutions, look at their bios, reach out for copies of papers, and make these professional ties. If you saw something here that was very interesting to you, then you could end up using that in your work as well. So these are your future colleagues and peers. And I encourage this cross-fertilization. So I think that we are coming to the end of our panel, and I really thank you, each person, each panelist, for contributing your paper and all of the work that you're doing in the world to make us understand all of these gendered and invisible things more visible and more understandable. Thank you.